Hi everyone, I'm Dr. Michael Miyazaki, and today we're going to discuss tissue management. Tissue management doesn't have to be hard, and yet it is something that we have to do every day. We're working in someone's mouth and the tissue is there right by the teeth that we're working on, and if we're doing a crown prep, we need to be able to see our margins, and we have to be sure that if we're going to take our impressions or an intraoral scan that we don't have blood covering our margins or tissue. So we're always kind of working with the tissue management, trying to be as gentle as we can so that the patient won't feel any discomfort once we're done. But when we're in there, we have to be able to be sure that we're controlling the tissue as best we can. So a situation like this where I'm trying to get the tissue out of the way so we can see the margins of our preparation. And especially as we begin our preparation, sometimes we need to get the tissue out of the way so that our burrs don't nick the tissue and cause even more bleeding. So we'll pack a cord to get the tissue out of the way, and then we'll go in and refine our margins. And so this is something that we're dealing with all the time. Luckily, Vista Apex has a lot of good products to assist us with our tissue management to make it easier and more effective. So that's what I'm going to be talking about today is we're going to be talking about how do we manage the tissue as we're working. So I'm going to move myself out of the way here. There you go. So if we have the tissue or the blood covering our tooth margin, whether it be for a direct restoration like a composite or an indirect restoration perhaps like a crown, if we have blood there, we can't get a good impression or intraoral scan. If I have tissue covering my margins, I'm not going to get a good impression, either those analog or digital. And if my margin is even for a direct composite restoration is covered, I need to get the tissue out of the way. So when I talk about tissue management, what we're talking about in this case is displacing the tissue either to protect it so our burrs don't nick that tissue, or perhaps to place a restoration, take that scan, or place some restorative material like a composite. What we have to do is we have to retract the tissues to be sure that we can visualize our preparation margins. Because if we can't see the margins, then whatever we're using to capture the margin, perhaps the scan isn't going to be able to do that either. And then if I'm using a cord to stop the bleeding, I want the cord to carry my hemostatic agents down into the sulcus, so while it's displacing the tissue, the hemostatic agents are getting deep down into the sulcus so that we have fewer or less crevicular fluids and bleeding. So we want to have our cord in this case help us with that. So let's talk about some of the ways that I've practiced tissue management. One is with retraction paste, and that's where we have usually like a cartwheel or some sort of container dispenser of this paste. We have some kind of needle that we put into the sulcus and we squeeze out this paste into the sulcus. Because it's a thick paste, it displaces the tissue, and that paste typically will have a hemostatic agent in it. It's almost like a clay, and that hemostatic agent will give us hemostasis. Some of the cons, it can be difficult to place this paste into a sulcus, especially if there's bleeding or if you've got really tight tissue. It's hard to get that clay-like material into the sulcus and to get it to stay there. Sometimes I know you get it in there and it starts to kind of get pushed out because the tissue is so tight. And then once you get it in there and you have to rinse it off to do your impression, again, whether it be analog or digital, you have to be sure you can rinse it out. And sometimes some of these are so clay-like that it takes a bit of effort to actually get the paste out of the sulcus. And they can be costly. Some of these pastes are fairly expensive relative to some of the other alternatives. And so retraction pastes just have not been one of my favorite ways of managing the tissue. Another way of managing the tissue is using equipment like lasers or electrosurgery type of units. The pros are that they're very fast because they're just vaporizing the tissue and they cauterize that tissue. So we get a separation between our hard tissue margin, let's say our crown margin, and the soft tissue. We just trough that area out so we have a physical space or separation. And because it's cauterizing the tissue, we stop the bleeding usually right away. What are some of the cons? Well, any of these things are going to cost money. You know, the equipment, the laser or the electrosurge unit. And then the tips. So if I'm using a laser, typically I'll have a tip, a fiber. And today they're usually single-use type of tips that we slide on and off the laser. Those cost money, could be $5 to $12 a tip. If it's a laser, typically we're going to have to get some kind of training to use that laser effectively. Some states are going to require a certification that we have been trained to use the laser. We've got the setup time. If I don't have the laser or electrosurgeon in my operatory and I decide that I need to use that, then we have to go fetch it from another operatory and bring it over, set it up with the tip, usually a foot pedal, and that just takes some time. If we're using a laser, we need to protect our eyes because the laser energy is attracted to the hemoglobin, and we have hemoglobin in our eyes, and so we have to make sure that we protect our eyes. So that leaves us with a very popular option, something that we learned to use in dental school, is cord. What are the pros of the cord? Well, it's going to displace the tissue because we're going to shove that cord down between the tissue and the tooth. And if we have a hemostatic agent in that cord, it will get carried down to help provide us with good hemostasis. Very cost effective. Cheapest way out of the three choices we have here are retraction paste or lasers or electrosurge units. What are some of the cons? It can too be difficult to place, especially if you've got tight tissue or maybe a deep sulcus. That tight tissue is you take that little piece of cord and you start to slip it into the sulcus, and as it goes in, especially if it's a braided type of cord that has a little bit of memory, it's kind of stiff, you start to work your way from the mesial to the distal, let's say. When you get to the distal, sometimes that mesial is starting to come back out. Sometimes the tissue is really tough, and we take our cord packer, and it's just hard to get that cord into the sulcus by itself. Then we have to remember to remove it. Sometimes what will happen is we'll tuck the cord into the sulcus and it will just disappear as it goes deep, but we can see our margin, so we're good when we take our impression. But when we pull that impression out, if it's an analog type impression, sometimes that cord does not come out with the impression, and so we have to remember to go back up there and remove it. I'm sure some of us have had the unfortunate instance to have left the cord up there. When the patient comes back a couple weeks later to get the final restoration bonded in or cemented, we see the tissues very inflamed, and of course we know what happened. There's a piece of cord up there, so we pull that out. The tissue will heal up. It's not nice to see, and it makes that cementation much more difficult typically. And then I think we have to respect the tissue attachment. So I tell the doctors, if I've got really thin tissue, I'm not going to put a really big cord in that area because it could damage the attachment. So what I'm going to do is typically use a smaller diameter cord to respect the soft tissue. So out of all these three choices, I'm going to focus on the last one, the cord, because I think that's probably one of the most common things that we use today. So if we've got an area where I need to get into the sulcus and I need to get the soft tissue out of the way, then a cord often works very easily. So I take my cord packer and I'm going to pack this around the tooth very carefully. Going to let it sit there for a little bit, let the hemostatic agent take effect, let that tissue just kind of get stretched out, and then I'm either going to pull the cord out, or I might, if I can, leave the cord there because I don't want to unsettle the tissue, and then we will take our impression or our scan and be ready to go. This Apex has cords. We have the Stat Pack knitted retraction cord, and we have the Stat Pack braided cord that is impregnated with epinephrine. So the ones that I typically will use are the knitted retraction cords. The braided is a little bit more difficult for me to place, and the epinephrine, again, it's contraindicated for patients with high blood pressure. So I don't find that I use the epinephrine containing cord. The Stat Pack with the epinephrine is 100% cotton braided so that the strands don't separate, and it makes it easier to pack because your packing instrument's not going to snag that cord and pull it back out. It is impregnated with stabilized racemic epinephrine. Here are the average concentrations of the epinephrine. So again, it is designed to displace the tissue. The epinephrine, of course, is there to stop the bleeding and control the circular fluids. But again, I would say that if you have a patient with high blood pressure or any health concerns, maybe you would not choose to use a cord with epinephrine. The cord sizes are the 00, the 0, and the 1. The cord that I find I use the most is the Stat Pack knitted retraction cord. It's compressible. It is knitted so that it doesn't really have a memory. It's easy to place. So that example I gave earlier where if I'm working from the mesial, say, to the distal, the mesial cord doesn't start pulling back out because this is a knitted cord, and wherever I place it, as I work my way down, there's really no memory to cause it to jump back out. It expands after placement, and it conforms that sulcular anatomy very well. It will absorb more of the hemostatic agent, and so it'll carry that down into the sulcus, which I really appreciate. And the other nice thing about the knitted cords is that if I, as we mentioned earlier, need to refine my margins, so I may do my rough prep, place my cord, and then go back in and kind of refine that preparation. If my burrs catch that cord, it won't pull it out typically, which I appreciate. So again, it's a cord designed to retract the sulcular tissues or to protect them, arrest the sulcular fluid seepage, and suppress the bleeding with the hemostatic agent, and sometimes just on its own because of the pressure. The cords are color-coded, and in this case we've got the 000, the 00, 0, 1, and 2. So we have a larger selection of sizes. And if you look at the container, there's a little ruler out here, and so this ruler just makes it very nice to measure out how much cord. So from the top down here, you have an inch, inch and a half, and 2 inches. So if your assistant is able to kind of learn that maybe a molar takes an inch and a half, maybe an anterior tooth might take an inch, or whatever you call out that you want, it's a very nice reference for your team. Then we have other adjuncts at Vista Apex. We have the Vista Packers. Then the agents that we've talked about before are QuickStat Free, which is a clear hemostatic gel. We've got the QuickStat Gel, which is a ferric sulfate gel, and we have the QuickStat Liquid, which is ferric sulfate liquid. The two on the left are the ones I use all the time, the Vista Packers and the QuickStat Free. Again, QuickStat Free is my favorite hemostatic agent. So the Vista Packers are foreign design. We have the plain edge that you can just use to place the cord into the sulcus. Serrated edge is what I like to use because I use a knitted cord, and the serrated edge just helps to grab onto the cord and then help me place it. It doesn't slip off the cord. So I like the serrated edge. And then we have the circlet style, which has which makes it more efficient when you're placing that cord. So what I do is I use a circlet serrated, and as I'm placing my cord packer onto that cord, I just kind of roll the packer, and I'm rolling down into the sulcus, and it's pushing the cord and holding it down. By kind of rolling that packer, you don't have the tendency of the cord getting stuck on the cord packer and getting pulled back out. So I like the circlet serrated cord packer. That's my favorite one. So here we have the standard plane, so it's just straight and not non-serrated at the tip. Here's a circlet plane, so now we've got no serrations, but it has a circular design. Then we've got a standard serrated, so straight again and serrated at the tip. And then we've got the circlet serrated, which is the circle design, but serrated all around that edge, that circular edge. And that is my favorite. I like the circlet serrated cord packer. And we have other adjuncts. Feel free to go visit the Vista Apex website. And on the website, they've got this educational brochure that talks about tissue management. So it talks about the QuickStat Gel, the QuickStat Liquid, the QuickStat Free, the technique of placing the cord, and I'm going to talk to you about that a little bit more, and all the different adjuncts that we have for efficient soft tissue management. So here's my protocol to get better impressions or intraoral scans. So once I finish the tooth preparation, I typically will take my QuickStat Free and apply it to any area, usually the entire prep, but especially to any area that might be bleeding. The QuickStat Free, remember, is a good hemostatic agent and astringent, so it's going to stop the bleeding and the crevicular fluids, but I'm also using it to lubricate the cord. So then my assistant hands me the knitted cord. I take my serrated circlet cord packer, and I place the cord right by the sulcus. I use my cord packer just to push it into the sulcus. And as I was mentioning it, I just kind of roll that serrated circlet cord packer into the sulcus as I'm working my way around the tooth. Now, once I get that cord in, I then would determine, do I need more cord, or is that one cord placement enough? If I can see my margin all the way around, and typically when the cord is going in, it's going to absorb the quick step free and stop the bleeding from the sulcus. I'll let that stay in place long enough that when I pull that cord out, if I need to, that the tissue's not just going to close back up. So I allow the cord to stay in place. I make sure that it's displacing the tissue adequately and that I'm getting hemostasis as needed. So if I can, I'll leave the cord in place. If the cord is down there and I can see the margins nice and clear and there's no bleeding, I'll just leave the cord down there and take my impression, whether it be analog or a control scan. Now, if I need to, I will remove the cord and take the impression. But typically, what I find most times is I'll just leave the cord there. Going back to the cord placement, remember, if I'm having to place multiple cords, a lot of times I'll put like a 00 down at the very bottom and then maybe a 1 on top of that, or maybe a 2 depending on how much tissue I have. So if I have to stack my cords, I'll put the smaller one down into the deeper area of the sulcus and my larger cord more towards the gingival margin. I want to make sure I can see the margins clearly. I want to make sure that there's no blood or fluids coming up. Especially if I'm doing an intraoral scan, I'll rinse that area off just to get the taste out if I've used a quick step free. I'll hit it with a lot of air to get as dry as I can, and I'll do my intraoral scan. If the cord, for some reason, or the tissue gets really dry, then before I pull the cord out, I'll just moisten that area before I pull the cord out so that it doesn't remove some of the epithelial layers of that soft tissue. Sometimes that cord, if you leave it in for a long time, kind of embeds itself in that tissue and dries up, and if you pull it out when it's dry, you can injure that soft tissue a little bit. So I will just moisten it, make sure I get the excess moisture out, and then pull the cord. So I hope this helps you understand how to manage the tissue better. Sometimes we're just trying to get the tissue out of the way. So if I'm doing a composite restoration, sometimes that restorative margin can go subgingivally. So I will place a cord down there just so we're not placing my direct composite and having to get the tissue out of the way. So this tissue management is just really important and something that we have to understand. It doesn't have to be hard, but we just have to understand how to make it work and how to do it as effectively as we can. So I hope you've enjoyed this program, kind of short and sweet. We're trying to develop this community of like-minded individuals. So if you like this information, hit the like button, hit subscribe. We'd love to be able to give you alerts when we post new programs up. And if you've got any suggestions, let me know. I can learn from all of you too. Some of you have some great tips and tricks, and I love learning myself. So thank you very much for watching this program, and I'll see you next week. Thank you.